Hey everyone, it's Rage's Band. Today we're diving deep into a topic that might sound a little intimidating at first, but is incredibly important for anyone who's ever been told they have a thyroid nodule. TIRADS. Now, what is that? TIRADS stands for Thyroid Imaging Reporting and Data System. Think of it like a standardized language that radiologists use to talk about thyroid nodules they see on an ultrasound. Its main purpose is to classify these nodules based on their features, helping doctors estimate the risk of that nodule being cancerous. This system is crucial because it helps us avoid unnecessary biopsies and anxiety. Not every lump or bump needs to be poked with a needle, and TIRADS helps us figure out which ones we can safely watch and which ones need a closer look. The vast majority of thyroid nodules, and I'm talking over 90%, are completely benign. They're just there, not causing any harm. That's why a system like TIRADS is so powerful. It gives us a structured way to assess the risk. Instead of just saying there's a nodule, a radiologist can assign a TIRADS score, which gives your doctor a much clearer picture. For example, a low TIRADS score suggests the nodule is almost certainly benign, maybe just a simple fluid-filled cyst. This allows us to say, okay, we see this, but it looks very friendly. Let's just keep an eye on it. It's all about making informed, evidence-based decisions and reducing patient stress. So in this video, we're going to break down the entire TIRADS system category by category. We'll look at what each score means, from TR1, which is a completely normal thyroid, all the way up to TR5, which flags features that are more suspicious. We'll also touch on some of the different versions of TIRADS used around the world, because yes, there are a few variations. My goal here is to demystify this report you might get from your doctor. I want to empower you with knowledge so that if you see TIRADS 3 on a piece of paper, you'll have a solid understanding of what that actually means for your health. Let's get into it. Let's start with the best possible result you can get on a thyroid ultrasound report, TIRADS 1 or TR1. This is essentially the all-clear signal. When a radiologist assigns a TR1 classification, it means they've looked at your entire thyroid gland and have found absolutely nothing to report. There are no nodules, no cysts, no abnormalities whatsoever. Your thyroid tissue appears uniform and healthy. It's the baseline, the picture of a normal thyroid gland. So, if you ever get a report back that says TR1, you can take a deep breath and relax. It's the gold standard of thyroid health from an imaging perspective. This category is straightforward, but it's a crucial part of the system because it establishes what normal looks like. In medicine, we can't identify the abnormal without having a very clear definition of what is normal. TR1 provides that foundation for the entire TIRADS scale. It's the starting point from which all other classifications deviate. Think of it as a clean slate. There's no need for follow-up imaging, no need for biopsies, and no need for concern based on this result. It's the report everyone hopes for when they go in for a thyroid ultrasound. Moving on to TIRADS 2 or TR2. This category is also fantastic news. A TR2 classification means that while a nodule or nodules were found, they have features that are definitively benign. There is a 0% risk of malignancy associated with these findings. We are completely confident that what we're seeing is not cancerous. So what kind of things fall into this category? We're typically talking about simple cysts, which are like little fluid-filled bubbles. They're very common and harmless. Another classic TR2 finding is something called a spongiform nodule. Under the ultrasound, it literally looks like a sponge with many tiny cystic spaces, and this appearance is a hallmark of a benign nodule. When a radiologist sees these features, they can confidently label the finding as TR2. This tells your doctor that while there is something there, it requires no further investigation. No biopsy is needed, and often no follow-up is necessary unless the nodule is very large and causing symptoms, which is a separate issue. The key takeaway for TR2 is that the features are so characteristically non-cancerous that we can dismiss the risk of malignancy entirely. It provides immense peace of mind and is another example of how TIRADS helps prevent unnecessary medical procedures and the anxiety that comes with them. Now we're getting into TIRADS 3 or TR3. This category is for nodules that are classified as low suspicion. This means there is a very low probability of them being cancerous, typically estimated to be less than 5%. So What does a TR3 nodule look like on an ultrasound? Usually it's a nodule that is mostly cystic, meaning it's filled with fluid, but it has a solid component to it. The key here is that it lacks any of the other more worrisome features we'll talk about in a minute, like irregular margins or microcalcifications. It's a smooth, well-defined nodule that just happens to not be a simple cyst. Because the risk is very low but not zero, the recommendation for a TR3 nodule depends on its size. For smaller TR3 nodules, the typical approach is just to monitor them. Your doctor might recommend a follow-up ultrasound in a year or two just to make sure it isn't changing or growing. If the nodule is larger, say over 2.5 centimeters, a fine needle aspiration biopsy might be considered to be absolutely certain. But for the most part, TR3 is a watch and wait category. It's about being prudent and monitoring, not about immediate alarm. Welcome to TIRADS 4, or TR4. This is the moderately suspicious category, and it's where we start to pay closer attention. The risk of malignancy for a TR4 nodule is estimated to be in the range of 5 to 20%. The features that land a nodule in this category are more concerning. We're often looking at a nodule that is solid or almost entirely solid. It might also be hypoechoic, which is a fancy term meaning it appears darker than the surrounding thyroid tissue on the ultrasound. This suggests it's denser than the normal tissue. Another feature that can push a nodule into the TR4 category is the presence of microcalcifications, which are tiny specks of calcium within the nodule. Because of this increased level of suspicion, the recommendation for TR4 nodules is more proactive. A fine needle aspiration, or FNA biopsy, is generally recommended for any TR4 nodule that is larger than 1.5 centimeters. For smaller ones, a period of close observation with a follow-up ultrasound in a shorter time frame, like 6 to 12 months, might be chosen. The goal here is to catch any potential issue early. TR4 doesn't mean you have cancer, it just means there are enough features present that we need to get a tissue sample to know for sure what's going on. Finally, we arrive at TIRADS 5, or TR5. This is the highly suspicious category. When a nodule is classified as TR5, it carries a significant risk of being malignant, typically estimated to be greater than 20% and can be much higher depending on the combination of features. These are the nodules that raise red flags for radiologists and endocrinologists. The ultrasound features that define a TR5 nodule are the most concerning ones. This includes being very hypoechoic, meaning it's much darker than the surrounding tissue. It might have irregular or spiculated margins, meaning its borders aren't smooth but are instead jagged or fuzzy, suggesting it could be invading nearby tissue. Another classic TR5 feature is a shape that is taller than wide, which is a strong predictor of malignancy. The presence of microcalcifications also adds to the suspicion. If a nodule has one or more of these characteristics, it will be classified as TR5. The recommendation here is quite clear. A fine needle aspiration, or FNA, biopsy is almost always recommended for any TR5 nodule larger than 1 centimeter. For even smaller ones, between 0.5 centimeter and 1 centimeter, a biopsy is often still considered. TR5 is the system's signal to act decisively and get a definitive diagnosis. Now, it's important to know that the TIRADS I've described isn't the only system out there. Let's talk about a few variations, starting with EU TIRADS. As the name suggests, this is the version developed and predominantly used by the European Thyroid Association. The fundamental goal is exactly the same: to stratify the risk of thyroid nodules based on ultrasound features to guide management. It's like having two different recipes that aim to bake the same delicious cake. The end product, a risk assessment, is similar, but the ingredients and steps can be slightly different. EU TIRADS also uses a 5-point scale, from EU TIRADS 1, which is normal, to EU TIRADS 5, which is high risk. The main differences lie in the specific criteria and how they're weighted. For example, EU TIRADS places a strong emphasis on the echogenicity of the nodule, how dark or bright it appears, as a primary sorting tool. It also has slightly different size thresholds for recommending a biopsy compared to its American counterpart. While a radiologist in the US might be using ACR TIRADS, a radiologist in Germany or France is likely using EU TIRADS. It's a good reminder that medicine is a global practice, and while the principles are universal, the specific guidelines can have regional variations. Let's talk about the version that is most commonly used in the United States, ACR TIRADS. This was developed by the American College of Radiology, which is where the ACR in the name comes from. This is the system that really popularized the points-based approach, and we'll dive into that a little more in a bit. So, instead of just subjectively putting a nodule into a category, ACR TIRADS actually assigns points for various features. The radiologist goes down a checklist, adding up points for things like composition, echogenicity, shape, margins, and echogenic foci, such as calcifications. The total point score then determines the final TR level, ranging from TR1 to TR5. This point system was designed to make the classification more objective and reproducible. The idea is that two different radiologists looking at the same nodule should, by following the point system, arrive at the same TR classification. This standardization is incredibly valuable for ensuring consistent patient care across different hospitals and clinics. It provides a clear data-driven framework for decision-making. So, when you get a report in the US, it will likely say ACR TIRADS, and there might even be a breakdown of the points that led to your final score. It's the official methodical approach that's favored in American radiology. Another important variation to know about is K-TIRADS, which comes from the Korean Society of Thyroid Radiology. Why is a Korean version so significant? Well, because South Korea has one of the most extensive thyroid cancer screening programs in the world, which means they have a vast amount of data on thyroid nodules and their outcomes. This experience has really shaped their approach. K-TIRADS is generally considered to be a bit more aggressive in its recommendations for biopsy compared to the American or European systems. It often suggests biopsying smaller nodules if they have suspicious features. This approach stems from a healthcare philosophy that prioritizes early detection, sometimes at the risk of identifying and treating very small, slow-growing cancers that might never have caused a problem, a concept known as overdiagnosis. The K-TIRADS system uses a pattern-based approach, categorizing nodules into high suspicion, intermediate suspicion, or low suspicion patterns before assigning a final K-TIRADS number. It's a slightly different way of thinking about the features. Shaped by a unique national experience with thyroid cancer screening, it really highlights how cultural and systemic factors can influence medical guidelines. Before TIRADS became the dominant force, another major system was widely used, and it's still relevant today, the ATA risk stratification system. This was developed by the American Thyroid Association, or ATA. Its goal is identical to TIRADS, to predict the risk of malignancy in a thyroid nodule to guide biopsy decisions. However, its structure is different. Instead of the TR1 to TR5 numeric scale, the ATA system uses descriptive categories: high suspicion, intermediate suspicion, low suspicion, very low suspicion, and benign. Each category is defined by a specific pattern of ultrasound findings. You can kind of think of the ATA system and TIRADS as two different languages describing the same thing. A high suspicion nodule in the ATA system has the same features as a TR5 nodule in the TIRADS system. Many endocrinologists and surgeons who have been practicing for a long time are very comfortable with the ATA guidelines, and you may still see its terminology used in clinical notes or reports. While ACR TIRADS is becoming the standard for radiology reporting, the ATA guidelines remain highly influential, especially in the overall clinical management of thyroid nodules beyond just the initial imaging. Let's circle back and look more closely at the engine behind the ACR TIRADS system, the points. This is where the magic of standardization really happens. The radiologist evaluates the nodule across 5 different categories and assigns points for each. First is composition. Is it cystic, which gets 0 points, spongiform, also 0 points, mixed cystic and solid, that's 1 point, or solid, which is 2 points. Next is echogenicity. Is it anechoic, 0 points, hyperechoic, 1 point, hypoechoic, 2 points, or very hypoechoic, which is 3 points. Each choice adds to a running total. It's a step-by-step methodical evaluation that leaves little room for subjective interpretation. Then they assess shape. Is it wider than tall, which is 0 points, or taller than wide, which is 3 points? This is a simple but powerful predictor. After that, margin. Is it smooth? 0 points. Ill-defined? Also 0 points. Lobulated or irregular? That's 2 points. Or does it have extrathyroidal extension, which is 3 points? Finally, echogenic foci. Are there none? 0 points. Large comet tail artifacts? 0 points. Macrocalcifications? 1 point. Peripheral calcifications? 2 points. Or punctate echogenic foci, which are microcalcifications? 3 points. The points are all added up, and the total score determines the final classification. 0 points is TR1, 2 points is TR2, 3 points is TR3, 4 to 6 points is TR4, and 7 or more points is TR5. All right, that was a lot of information, but I really hope breaking it down step by step helped demystify the whole TIRADS system. The big takeaway here is that this is a tool designed to help you and your doctor make the best decision, and most importantly, to avoid unnecessary procedures. Seeing a number like TR3, TR4, or even TR5 on a report can be scary, but remember, it's not a diagnosis, it's a risk assessment. It's a piece of the puzzle that guides the next step, which is often a simple, low-risk biopsy to get a definitive answer. The overwhelming majority of nodules, even some in the higher risk categories, turn out to be benign. Knowledge is power, especially when it comes to your health. Understanding what these terms mean allows you to have a more productive conversation with your doctor. You can ask smarter questions. You can understand the why behind their recommendation to watch and wait, or to proceed with a biopsy. This really reduces anxiety because it replaces fear of the unknown with a clear understanding of the process. Your health journey is a partnership between you and your healthcare team. And the more informed you are, the better partner you can be in your own care. So don't be afraid of the medical jargon. Be curious, ask questions, and please share this video with anyone you know who might be going through this. My goal is always to arm you with accurate, accessible health information so you can stay healthy and informed. As always, stay happy and healthy, and I'll see you in the next video.